Good afternoon, everyone. My name is Sharon Byron. I am the Marketing Manager for TruCode, and we're very excited to present today's webinar, Documentation Improvement for Quality and Value, which is co-sponsored by Chartwise Medical Systems. I'm pleased to introduce today's presenter, Dr. Jon Elion. Dr. Elion is a graduate of Brown University, both for undergrad and medical school, trained in internal medicine at the University of Wisconsin, and in cardiology at Duke University. He's currently an associate professor of medicine at Brown University and still practices cardiology part-time at the Miriam Hospital in Providence. He serves on several hospital finance committees and boards. In 1994, he founded HeartLab, the world's leading designer and supplier of digital image and information networks for cardiology. He's chaired the Cardiology Working Group for the DICOM standard and wrote and coordinated the landmark multi-vendor demonstration of the DICOM standard in cardiology. He's also chaired as the technical and clinical planning committees of integrating the healthcare enterprise. Dr. Elion is the founder and CEO of Chartwise Medical Systems, whose premier product, Chartwise 2.0, is a comprehensive system to support clinical documentation improvement. So before I hand it over to Dr. Elion, I want to review a few housekeeping rules to ensure a successful webinar. First, all attendees are in listen-only mode, which means you will need to use your control panel to communicate. You can find your control panel on the right-hand side of your screen. If you need to minimize the control panel to see the screen better, you can collapse and expand it by clicking on the little red box with the arrow. If you want to ask a question, please do that. And you can do that in the questions section of the control panel, which is towards the bottom. To ask a question, just click on the plus button. It will open up a text box, and you can type your question in the box. We will be monitoring your questions throughout the presentation, and Dr. Elion will pause periodically for questions, and we'll raise them at that time. So please feel free to ask us any questions you have. I also want to point out that handouts for today's presentation can be accessed from the handouts section of the control panel if you'd like to print those out for reference. And we'll also be emailing those out at the conclusion of the webinar. Finally, and most importantly, we want to make sure you receive your CEUs. So tomorrow morning, we will be sending out an email to all attendees with a link to a brief webinar evaluation. Please complete this evaluation, and once you submit your response, you'll be brought to a link where you can download your CEU certificate. And if you have any questions or any problems with this, you can always email me just by responding to your webinar invitation, and I'll make sure that you get your certificate. Okay, with that, I will hand it over to Dr. Elion. Thank you.
Thank you very much. It's great to be here. I sit on many committees at the hospital, as was mentioned, and just yesterday was in our hospital's quality oversight committee. And it was kind of amusing to me that many of the topics that we'll be covering today in the webinar were being brought up at that meeting. So these are on lots of people's minds. These are fairly current kinds of issues that we'll be talking about. And hopefully everybody's got the screen, the slide presentation in front of you. There we go. So today, there are some goals and objectives that are listed. I do want to take this opportunity to point out that the slide handout is a really handy thing for you to have. It is available on the handout pull-down accordion section of that control panel. So make sure you've got that, not necessarily for following along today, but for future reference. There's a lot of things that I've put on some of the slides, a lot of text that I'm not going to sit and read to you. They're on the slides, so they show up in the handout. But these are the things that I'd like to be reviewing today, and a good example of things that are on the slide that I'm not going to read to you. I didn't realize that my introduction was that long. I've got just a few highlights to repeat that. My first paying job in hospital-based software was the summer of 1969, and I suspect that many of you on the call today were not born yet in 1969. That was the Leahy Clinic when it was still in Kenmore Square in Boston. And that was working in their IT department. I don't think it was called IT back then, but doing a lot in medical computing ever since then, really without a break. I am a Duke-trained cardiologist, and I take care of patients. I take a turn periodically at the hospital, and that means I'm writing clinical notes, and that means that our documentation improvement staff is reviewing my notes and on occasion asking me to clarify things. That reminds me of the old commercial where the fellow says, I'm not just the president of the Hair Club for Men, I'm also a customer. So I make technology that helps with documentation improvement, but I'm on the receiving end of all of that as well. I do teach at Brown University, and actually I mention that because today I'm going to be wearing that hat. I'm going to be trying to tackle the questions at hand more from the academic position as Associate Professor of Medicine rather than talking about any of our software or the company. Administration-wise, I do sit on various boards and committees, so I see all that, and I've been on the commercial side as well. So I come at the topic today with all of those backgrounds in hand, and all of those are at play. Before we really get underway, I wanted to start the same way that I start many of my talks, which is just a reminder that if you are just out to improve the reimbursement at your hospital, you're going to miss the opportunity to get the high quality medical record. We all know what that is, a medical record that designates and describes everything about the patient, the diagnoses, the treatments, the histories, the outcomes of what's underway. And if you're just after reimbursement and improving your clinical notes, you're going to miss that. But if you pursue the high quality medical record, the proper reimbursement will follow. Now notice I said proper reimbursement, not necessarily increased reimbursement, because sometimes there are things that at the beginning of an admission we think might be going on. For example, a patient might have a myocardial infarction, but it turns out to be a gastroesophageal reflux or something less lucrative. So reimbursements can go down, but you've got to go after the high quality medical record. That's the prime directive. It's not just about reimbursement. You've got to have a complete record because you need accurate coded data essential for basically anything that you hear about these days in the newspaper, on TV, when they're talking about healthcare, healthcare economics, the distribution of healthcare, decision-making on healthcare policies. All of this is premised on the fact that you have a lot of very accurate and coded information. And it's true, I am biased, but in order to get that accurate coded information, you've got to have the documentation. Physician documentation is really the cornerstone of the accurate coding. So today I want to be going over three basic areas. I want to talk about quality. I want to talk about metrics of how we measure the things that we're doing. And I want to talk about value-based purchasing and those types of issues. So let's start with quality. And the quality measures that are most frequently used basically are expressed as a ratio, referred to as the O to E ratio, which means the observed to expected. Let's explore what that means a little bit. If you're looking at a certain mortality rate in a group of patients, and it's important to remember that there is an expected mortality that can be calculated based on the disease and the various comorbidities that go along with it. And you're going to be evaluated at your hospital to see whether the observed mortality rate, how many deaths you actually have at the hospital, is that higher or lower than what is expected. If the ratio is greater than 1, that means that that's a bad thing. You have more observed events than were expected. What this also means is that you have an opportunity to impact the denominator, the E, the expected rate. And you do that by fully documenting all of the comorbidities. And that is going to improve your scores. And it's one of the first things in a quality initiative that you should be looking at, and you will hear this a few times today, that you should be looking at your documentation and you should be looking at your coding, because those are two places that you want to make sure that you're capturing everything. We had a situation at my hospital where we felt that the mortality rate from sepsis was too high. We had an O to E ratio greater than 1, means that when we compared ourselves to our peer group, that we had higher ratios than were expected. So the first thing that we did at our hospital was a very active chart review and a code audit and coding review, and we found that we had both problems, that the physicians were not documenting fully the comorbidities comorbidities, and therefore the patients didn't seem as sick as they actually were, and their expected number was therefore off. And also that there were some issues where coding wasn't fully capturing and coding the things that were documented on the chart. And as it turned out, our O to E ratio, our quality measure, was just fine once we corrected those two things. Now, we weren't happy with that, and we've got an initiative for sepsis and sepsis treatment, as many hospitals have these days, to even do better than that. So first thing in terms of CDI, clinical documentation improvement, how can it impact quality measures? Fully document all of the comorbid situations that impacts your expected mortality rate. And just going to review, some of these are actually issues that will show up on several slides. So some of these are a repeat, but they're done on purpose. Used to say that if it's not documented, it didn't happen. If the doctor didn't write it, it didn't happen. Now we have to modify that a little bit and say if it's not written properly, then it didn't happen. So now physicians are being asked to use magic words that maybe they didn't learn in medical school, maybe are not part of their standard practice. When I first got into this field, remember, I'm a board-certified cardiologist, I was amazed to hear the term acute systolic congestive heart failure. I had made it all the way through medical school, through cardiology training, and beyond, and had never heard that term, acute systolic congestive heart failure. Now, I figured it out pretty quick, but that's a coding term and not necessarily a clinical term, at least not one that's used for the most part clinically. There's a lot of disorders that I see as a cardiologist that it's very hard to categorize into the coding equivalent. And I'm just going to give you one example. I'm assuming that we've got some coders on the webinar. We've got some clinical people, maybe some CDI people. So I hope many of these terms are familiar to you. But if a patient has a faulty aortic valve from the heart to the aorta, and if that valve is leaking, that's called aortic insufficiency or aortic regurgitation, it can be bad enough that fluid will back up into the lungs and they present in failure. Now, the pump might be just fine, so they are not having a problem with a weakened heart muscle. The sole problem is that that valve is leaking and it's backing up into the lungs. So they have some type of, if they come in with an acute episode, they have acute heart failure. Now, question, is that systolic or diastolic? And I love asking that question of cardiologists because they just look at me like I have three heads, because it really doesn't make clinical sense. It doesn't make cardiologic sense. The systolic function of the ventricle is fine. The diastolic function is fine, but there's the patient sitting there in florid failure because of the leaky aortic valve. It turns out that, as my understanding of the coding clinics would indicate, that because the abnormality is happening during diastole, that's when the aortic valve leaks, that you could code that as diastolic dysfunction. But a cardiologist would argue that the diastolic function of the heart muscle is just fine. So I only wanted to just underscore that, because there are dozens and dozens of examples that I could offer for that disconnect between what is a clinically relevant note versus what you need to actually code from. So in CDI, you want to make sure that we're looking at the expected quality and try not to overlook things. And many diagnoses will impact the risk of mortality or severity of illness without changing the DRG or the reimbursement. Remember at the beginning I said go after the full medical record, not just the stuff that gets you the reimbursement. But if you're just finding diagnoses and trying to nudge the doctor to document the things impacting reimbursement, you will miss the diagnoses or some of the diagnoses that impact risk of mortality, which is important today and is becoming more and more important in the new healthcare environment. So ACTIS, the Association of Clinical Documentation Improvement Specialists, did a survey, and they found that 75% of documentation specialists reported that they queried not just for reimbursement, but they queried also for quality. And And on one hand, many people are happy to hear that the number is that high, 75%. I'm dismayed because it should be 100%. This still says that there's hospitals out there where the documentation specialists are being asked to simply query for only things that are increasing the reimbursement, and that's quite distressing. Also, they reported that doing the queries for quality measures hinders their traditional CDI productivity. This one is particularly puzzling to me because querying for everything is part of CDI productivity and part of what they should be doing. It tells me that these hospitals are an environment where the CDS is not supposed to be going after those quality measures. That's for other people. Just stick to the stuff that gives us the reimbursement. So that's very discouraging. And it's led to the third point, which is many of the documentation specialists think that working on quality measures is not part of a traditional CDI chart review. And we'll get shortly to some discussions about value-based purchasing and other things where these are now directly impacting reimbursement, although it's a little harder to calculate the dollar value, harder than just the case mix index. So how do you provide a good environment for data and for quality measures? These suggestions are well-intended but difficult to carry out. For example, educating executives on the need to consider all aspects of documentation. I have had a number of documentation improvement programs and CDI managers who have been successful at doing that. One hospital actually said that their CDI program, they simply stopped reporting all dollar figures to the C-suite. And of course, the CFO was very upset the first few times they saw that report, but finally caught on that there was more to documentation improvement than just the reimbursement. And then scheduling periodic code reviews. I warned you that I'd be talking and mentioning this a few times. It can be a sticky wicket depending on your hospital, but it is always a good idea. You want to make sure that everybody is documenting thoroughly, and then scheduling periodic code reviews is a good idea just to get some confidence that the things that are being documented are being coded in a proper fashion. Now, I'm going to try very hard today to stay away from politics. Although we will reference a few things that are happening in terms of healthcare legislation. But I do, despite that attempt to stay away from politics, I want to get on a soapbox just briefly and talk about something that's a very disturbing trend that I'm seeing, that is prioritizing reviews. Now, we know in the coding arena that many years ago, people figured out that there were some coders, if you've got a large group, some coders were kind of cherry-picking charts to code and were churning through large numbers of charts, but being very selective in what they were picking. And I believe that that practice is discouraged these days, as it was not felt to be a good idea or promoting the greatest productivity or accuracy. Unfortunately, the idea of prioritizing work has come back, and it's in the area of documentation improvement. And the goal should be at your hospital, if you have a documentation improvement program, to document accurately and fully on all of your patients, not just some. And that means you need to review all of the admissions, not just a few. For example, our customers actually, on the average, get to 98% of their targeted admissions. That's the review rate that they have. So prioritizing on top of that, it's hard to improve on that. But if you do have a very low productivity or a low review rate, there are some people out there suggesting that maybe you could prioritize and pick and choose the charts that you want to review. And that just seems bass-ackwards to me, and it is not what we ought to be doing out there. So I just want to kind of, last slide or two on my soapbox, just say if you really are trying to prioritize, do so responsibly. Don't just be cherry-picking. You should be trying to review all of your charts for opportunities for documentation improvement. And I believe that this is kind of going hand in hand with a very disturbing practice that just doesn't seem to want to go away, and that is the strategy of finding an MCC and then moving on. And by that I mean an MCC is a major complication comorbidity. Once you have found that MCC, you've got maximum reimbursement on a DRG patient, but you may not have fully documented the severity of illness, risk of mortality, and other areas that are going to impact. So just taking a peek, and if I understand correctly, there's no questions that have come in yet. But I do want to remind people that I'm going to pause every now and then just to see if there's questions about any of the things that I've said, and happy to make this as interactive as the electronics permit. Obviously a little tougher than when we're all in person, and I can watch the body language and you can raise your hand, but would love to hear some questions from you and try and respond to those live. If there's questions that we either don't get to or kind of come in late, then we'll try and do that via email follow-up with people, but much better if you want to get your questions in during the talk, and happy to do that. So I'm going to move on because I see on the screen there's no questions into us yet, but I want to talk about metrics. Metrics in general, and then talk about some for clinical documentation improvement. Why do you want to measure stuff? And that's an interesting question that some people sometimes find difficult to answer. One of my favorite parameters that I like to look at when evaluating something that's being measured is to see if it's a KPI, a key performance indicator. That means that it's a measurable value that really underscores the underlying processes going on at the organization that you're using to try and achieve your objectives. And a KPI is only as valuable as the action it inspires. Now, to me, even though there's some people that will distinguish between a KPI and a quality indicator, to me they are kind of versions of the same thing. So KPIs and quality indicators, extremely important to select them well. Now I want to give an example. It was one of my very first classes in quality management. We learned that there's a quality indicator that you can come up with to see how satisfied McDonald's customers are as they drive through the drive-through window. And that is how long were they in the line. It meets the three basic criteria. First of all, it is a reflection of underlying quality. It is measurable, and it can be impacted. So that's one aspect of a clinical indicator, a quality indicator, or in this case, a KPI. Those three aspects: it needs to reflect quality, it needs to be measurable, needs to be impactable. So you may have also heard another term, which is SMART indicators, SMART KPIs. And the abbreviations actually are different depending on which articles you're reading, but basically it's specifically what do you want to do. You've got to get very specific about it. You need to know when you've actually reached it, and you need to be able to measure it. You need to be able to attain the goal. It has to be something within your power to actually impact. It should fit into the big picture of things, and you need to know exactly when you want it done. And as I look at various requests of people that want metrics and want reports on their documentation improvement process, I'm concerned that some of them are using what I call vanity metrics. And in case you didn't recognize it, this is a very famous painting by Caravaggio called The Narcissus, as Narcissus is staring into the water, studying reflection, and kind of saying, oh, how good looking you are. And vanity metrics are unfortunately rather prevalent when people are just measuring just to have something to report and say, oh, look how wonderful we are. But it often fails the test of being a quality indicator. It doesn't reflect processes. It doesn't reflect your the core culture and the thing that you're actually trying to change. So whenever you are trying to measure something and come up with metrics at your program, put it through the test of asking yourself, why is it important to have this measured? How are you going to impact it? And does it really reflect the underlying processes that you're trying to improve? Now, before I go too far, I want to just explain a concept that we use quite often, which is called baseline. And even though I'm not talking about the ChartWise software today, I did just grab a screen from one of our one of our demos, and this is basically showing the difference between the baseline set of codes that were present on a patient when they first came in the hospital, and then as the CDS, Clinical Documentation Specialist, was working and doing various queries and adding various diagnoses, and finally up to the very end and working for is the list of diagnoses as it's being ready to be sent off to coding and billing. And the term that I want to linger on is called baseline. And our concept is that there is information on the chart that's codable without CDI being involved. And that's a very important measure. And that's something that if you're going to measure the impact of your program, you measure it against that baseline. Let me give you some examples of doing it wrong. There is an approach that will say we're going to take the admitting diagnosis and compare it to the discharge diagnosis. And if the CDI staff was involved, then the impact they had was the difference between the admitting diagnosis and the discharge diagnosis in terms of reimbursement. Well, let's say the patient came in with belly pain. That was their admitting diagnosis, abdominal pain. After careful study, it turns out to be acute cholecystitis, hot gallbladder. They undergo surgery for the hot gallbladder, and afterwards, the patient develops some breathlessness. They have a fluid overload, and the cardiologist is called, and he correctly documents acute on chronic systolic congestive heart failure. So the discharge diagnoses will be the cholecystectomy procedure, the acute cholecystitis, and the acute on chronic systolic congestive heart failure, which, by the way, is a MCC, a major complication. So the maximum reimbursement was obtained. In the midst of all of that, the documentation specialist had queried the doctor for the abnormal GFR, glomerular filtration rate, and was asking about the chronic kidney disease. So the CDI was involved, CDI staff was involved, and the difference in reimbursement is the difference between abdominal pain and the cholecystectomy, acute cholecystitis, acute on chronic systolic congestive heart failure. So it is unfair to take credit for that change in reimbursement. And you're going to have to think on this a little bit, but the impact that the CDI process had on that admission was $0. The surgeon did not operate because you queried on the glomerular filtration rate. And the maximum reimbursement happened because the cardiologist correctly diagnosed the major complication or documented the major complication. So the impact in that case would be $0. However, by getting more accurate and complete documentation about the chronic kidney disease, the risk of mortality and severity of illness was increased for that particular admission. So it's important to understand baseline and understand what it is that you're measuring. If you're trying to come up with an impact for your program, an impact for a query, what the doctors are doing, what each CDS is doing, you need to know what to compare it against. And simply using admitting diagnosis versus discharge diagnosis is not fair. It's not accurate. So just for laughs, I kind of went through a lot of our reports that we churn out and kind of came up with a very arbitrary list, and this probably changes from week to week, about what are some of our more commonly requested reports. And sure enough, despite all of the preaching about don't be going after reimbursement, one of the more popular reports is looking at the financial impact by documentation improvement specialist. And again, we do that very carefully and meticulously against a baseline as I've described and not an arbitrary number. Looking at readmission, CDI productivity, query responses, all of those are important. Just a few quick points. CDI productivity is interesting because I don't know what the target numbers should be. If you are reviewing charts in the intensive care unit, you probably are not getting to many a day, but if you're reviewing well baby deliveries, normal healthy children being delivered, then you're getting to a lot per day. People are coming up with numbers and targets for how many charts should be reviewed, but there is no known standard. So you've got to be very careful about that. Query responses are interesting because the traditional thing to measure is how often did the physician answer the query. We love Dr. Elion because he always answers his queries. No, Dr. Elion's an idiot because you keep querying him about the same thing over and over and he's not learning. And furthermore, he takes 2 to 3 weeks to answer after the chart has already been coded and billed when it's too late to have an impact. So query response is one you really want to be looking at query response time. How long did it actually take to answer? I don't have time to go over all of these, although I have examples of, I think, 3 of them, but 2 of them are in yellow, highlighted in yellow, because these are things that can be helpful in looking at quality and value. The SOI is severity of illness, and ROM is risk of mortality, and that's one of the things that you want to be looking at to see how you are, what I call moving the needle. Is the documentation improvement process actually helping you document how sick the patient is and helping do that in a more complete fashion? So that is something that you can look at. And as we have talked about and seen, these can change independent of the financial reimbursement or the DRG shift. And then the other thing is there are various things in quality. We have a variety of reports in that area. For example, just looking at core measures, looking at other groups of patients. The example I gave at my hospital where they were looking at sepsis would be an example of not a reportable core measure, but a very interesting thing for the quality department. So being able to put together groups of codes to produce reports for tracking one particular concept or another is extremely helpful. So here's just a sample of a kind of report that you might generate. This is very busy. It's going to be hard, I think. You might be able to see that on your screen, and it's going to be a little hard in the handout. But basically, this is just looking at the given hospital and breaking it down by documentation specialist. So CDS is clinical documentation specialist, and just looking on a month-by-month basis, you get some very interesting information here in terms of how many discharges were looked at and what was the impact on severity, severity of illness, risk of mortality, and so on. Another report I mentioned was core measures. Interesting that these are processes that are pretty well established at hospitals, but it's still difficult for some hospitals to get at the list of patients that need to be reported. And that's interesting and challenging, but you want to have quality involved during the admission and not just after the admission. We've done that with coding, haven't we? We've moved from the retrospective after discharge coding, and coding is getting a lot more involved concurrently, concurrent chart reviews while the patients are in the hospital. And the quality department is starting to get in on that as well. Don't tell me that 6 months ago I sent a patient home with a myocardial infarction and forgot to give them aspirin. That's not helpful. Why don't you tell me that tomorrow I am going to send a patient home with an acute myocardial infarction? Don't forget the aspirin. So quality is moving from retrospective to concurrent, and these types of reports simply help a quality person, quality manager, or members of their department find the patients and get to them concurrently while they're in the hospital. The next one I want to show you is it's a prototype. It's something that is kind of fun and challenging, and we'll talk a little bit more about PSIs, patient safety indicators, in a little bit. But in this report, this is a list of patients who are in the hospital who have possibly a PSI problem. And as we'll talk about, I'm just going to give you a little preview. A PSI, patient safety indicator, is something that might be a reportable complication that happened at your hospital, but there may be an exemption. There may be an exclusion that says it was okay, you don't have to report that. For example, iatrogenic pneumothorax, I just like saying that, iatrogenic pneumothorax, air in the lung cavity that was caused by something the doctor did, is reportable unless, and then there's a list of exclusions, one of which is a pleural effusion. If there was fluid in the lung, then you don't have to report that. So what this simple little grid shows you is which patients meet the inclusion criteria, which ones might have a reportable complication, and then which ones also have exclusions. So the red boxes means that they are going to have a reportable PSI and they don't have any exclusions. The example I gave, if one of those was an iatrogenic pneumothorax, you would go back, review the chart, find a chest x-ray that had pleural effusion. Remember, we can't code from the chest x-ray. You then query the physician about that pleural effusion, because if you can get that documented, that would be an exclusion and the PSI would not have to be reported. So having this concurrently by your quality people, having it at their fingertips and being able to track this down and chase it down is a very good way to start to get on top of your PSIs. So I want to get back to KPIs and key performance indicators. And I've just chosen arbitrarily 3 things that people might measure. The review rate, which means of the charts that you consider eligible for review, how many did you get to? Query rate. Of the charts that you reviewed, how many of them did you generate 1 or more queries for? And response rate, which is how often did the physician answer? So is review rate a good key performance indicator? I would say yes, it is, because it does reflect, I'm sorry, I'm just getting messages from the webinar that I'm trying to ignore. So the review rate is important because we've set as a goal at our hospital that we want to review 100% of the eligible records. And so having a number that I can track, having it one that I can impact, it does reflect the quality of my department. It meets all of the criteria. Review rate would be a very good key performance indicator. What about query rate? I'm not too sure about that one. And I actually have a hospital that one of the documentation specialists must think that he is being evaluated based on the number of queries that he generates, because he is the absolute superstar of making queries, but that doesn't say anything about the quality of his queries or of that review process. There is no target for a query rate. It's not like you should be querying on half of the charts that review or 20% of the charts that you review. So I'm raising a question mark as to whether that is a valuable key performance indicator. And I'm sorry, I can't advance the slide when the webinar is asking me questions, so that's why the occasional pause. So the response rate is, I've already indicated my disdain of that particular one. It's easy to measure, it's traditional, and it's something that I hear tossed around all the time, and labels are attached to physician about how often they answer their queries. They should be answering 100%. A really better thing is how quickly are they answering the query. That's a far more important number to have. So that's just some opinions. You may differ a little bit, but just trying to get used to looking at key performance indicators and looking at anything that you might measure and make sure that you're measuring something that can actually help you improve things. And when I was putting things together for KPIs, key performance indicator, I kind of came up across another set that maybe you don't think of them as key performance indicators. For me, I do. For those that don't know, KLAS, K-L-A-S, I don't believe it's an acronym for anything. It's kind of the J.D. Power of customer satisfaction of hospital software. And these are reports that come out periodically, and there's a variety of categories. And these are KPIs that vendors might use for their software, whichever software you're looking at, but you may also find useful. So I won't tell you which is the blue line and which is the red line, but if I'm showing it and showing it off, you could probably make a pretty good guess. But key performance indicators, there's a variety here that, again, they might be a little tough for you to read in the small version in the handout, but just looking at exactly, did it do what it said it was going to do? And would you recommend this? Would you do it again? And so on. So, I'm looking and I don't see any questions. Are there any that have come in that I'm not seeing? Do we have any questions pending?
Dr. Elion, I have a couple. One coder asked if it is okay to code a diagnosis that's ruled out, and I don't know if she meant ruled out or pending.
first I have to give a disclaimer. That's a coding question, and I'm not a coder. But I just have to say that I'm not just saying this because TruCode is sponsoring this webinar, but I use the TruCode encoder a lot. I've learned a lot about coding through using it. There's probably not a lot of practicing physicians that actually go to an encoder to try and write better notes or answer queries. So I can answer that, though, and because of my knowledge of that there are things that are different in the inpatient world and the outpatient world. So, for example, inpatient, if I say probable pneumonia, probable MI, those can be coded in the inpatient world, but as I understand it, would not be something that you would code in an outpatient setting. When I say that to physicians, it makes them turn all kinds of shades of green because they're very distressed that now they're being asked to learn all of these different coding rules. And I bring it up this way because it's a very important point to make to your physicians. Write a good note all the time. Don't write a different note in the outpatient setting than you do in the inpatient setting. Don't write a different note for a Medicare patient than you do for a Blue Cross Blue Shield patient. Write thoroughly and completely in all of those arenas and rely on the professionals that you have around you to understand the coding rules and let them do what they've been trained to do. It's not necessary for the physician to know about the probables and the rule outs and what can be billed in the inpatient or the outpatient arena. Got another one?
I have one more. The example that you gave earlier about the patient with cholecystitis and the cholecystectomy, where the cardiologist identified the acute and chronic systolic heart failure at the end, they wanted you to clarify whether you were saying that the heart failure was supposed to be the principal diagnosis as opposed to the cholecystitis.
Nope. So that was a comorbidity. That turns out to be a major comorbidity when worded correctly, as the cardiologist did. When you say acute systolic, that one's going to qualify as an MCC. Whereas if the doctor had just written a note that says, oh, that's just CHF, give them Lasix, that doesn't qualify as an MCC because of not using the proper terminology. So it was not the CDI staff that got clarification and got the explanation that led to the MCC. It was just a well-trained cardiologist who knew how to write a good note that led to that. So that point was that the CDI department can't take credit for the fact the doctor wrote a good note without prompting. If you're trying to look at CDI impact, the impact of your program on whatever metrics you're measuring, you do that using baseline versus the post-intervention.
And I have one more that just popped up as well. The question is, do CDI people traditionally do retrospective reviews, or are those pretty much just considered the purview of a coding staff?
Very interesting question. The retrospective, I'm going to have to say yes, because it would not be uncommon for the documentation specialist to continue looking at a chart for a couple of days after discharge. So technically, if you're looking at it on day 2 post-discharge, that would be retrospective. But typically, the review, the queries, the answering by the physicians, there's an aim to make that all concurrent. I am always amazed, and I'm not bragging, I think any physician will basically say this, but I'm amazed at what I can keep in my head about the patients that I have, so that if I get a query asked of me, I really rarely need to go back to the chart to find that information. I've got that in my mental fingertips, but 2 weeks later it might be a different matter altogether. So you want to get after the physician when things are hot, when they know about it, but CDI typically tends to be concurrent. When we're talking about inpatient, that is. Outpatient is something that is gaining a lot of interest, and in the outpatient arena, you're not going to be doing concurrent review while the patient is in the clinic setting. You're going to be doing review before the patient arrives at the clinic and then after they have left the clinic, but that's a topic for another day's discussion.
Have one more that came in. Do you want it now, or you want to hold it to the next time?
Oh, go for it.
Okay. This is a case where a query is issued and the diagnosis is documented on the query form only, not added into the medical record. They didn't clarify whether they were putting the query form in the record, but due to concerns about payers denying that case, they wanted to know if you would recommend going ahead and coding the diagnosis based on that query only and then fighting it out with the payer later if they choose to deny it.
Wow, that's a great question. I'll have to start by saying what my recommendation is, which is always a very strong recommendation to hospitals, and that is to not let the answered query suffice, but have the physician document in their progress note the information that they've also answered in the query. So doctors will rebel because they've got to do it twice, but that is clean. It is the best practice. And in fact, we've put some things in our software that actually let you track that and keep an eye on, did they not only answer in the query, but did they also answer in the chart? Now, the query itself, I'm always amused at people who say, oh, that's part of the medical record. Oh, that's not part of the medical record. No, everything that you've written is basically what's called discoverable. The lawyers can get hold of that. And there's no such thing to me as something that's not part of the medical record. But let's face it, that could be in a separate section. Who knows where the queries are? Is it in a miscellaneous section? Is it in a scan section? You don't know where it actually is in the electronic medical record. So technically, it is my opinion that one could be coding from a physician's signed document that happens just to be something that originated out of the CDI department. But I don't ever want to get to that discussion. If I'm having the battle over a denial over that particular issue, something's really wrong. So I just don't want to ever have that. That's why I'm recommending that best practices would be always have physician answer in their progress notes.
Thank you.
So I'm going to move along and basically now finally get to value and value-based purchasing. I warned you at the beginning that a lot of the slides have a lot of text on them, and it's there so it makes it into the handout. We're about to enter that section where there's a lot of wordy slides, and I'm not planning on reading them to you, but they're there so that you do have them to refer to later. If you have not already, you should discover the ahrq.gov website. So this slide is really in there just so that you've got the URL, you've got the website address up at the top. It's the qualityindicators.ahrq.gov. And this brings us to a discussion about value-based purchasing. And this is in 2 slides. And again, some of these points are made more than once. And I'm not going to read them all to you, but this is where I'm having trouble staying away from politics. Value-based purchasing is actually legislated by the Affordable Care Act. I'll take a deep breath and I'll pause while I let that sink in. All of the current discussions in Washington, to the best of my knowledge, do not touch anything about value-based purchasing. So the discussion, the use of the word repeal is actually, it's more correct to say that they are attempting to repeal certain provisions, but not the entire thing. You may have seen a press conference where there was a little tiny bill compared to this huge stack of paper for the Affordable Care Act. The Affordable Care Act is very large. It is very long. It is very comprehensive because it has a huge amount of things that just nobody is talking about on TV or in the newspapers about health care and the way that health care reimbursement is actually done. So the value-based purchasing is one of those things, and to the best of my knowledge, none of the changes that are currently being discussed are going to be changing this. It is here with us. So pay for performance, value-based purchasing. I'm going to use these terms somewhat interchangeably, although they are slightly different. And for the most part, the value-based purchasing is the carrot and stick approach where you are being offered a financial incentive for doing a better job with the care, as we'll talk about in another slide or two. But you also have penalties if you're doing a decidedly worse measure. But now quality measures start to really come to the forefront, and it's extremely important. Now, something that is fairly scary for people when they learn about it by surprise is that 60% of reimbursements by 2018 will be based on pay for performance and value-based purchasing methodologies. And that 2018 reimbursement will be based on your 2016 performance. So there are CFOs who are just waking up to the fact that they're way behind the curve, and they've been focusing on case mix index for too long, and suddenly they have a huge part of their reimbursement that is going to be based on things that they haven't been thinking about. So this is where value-based purchasing, remember I said at the beginning, it's a very hot topic at a lot of hospital committee meetings, because people are realizing how important it is and how much of our reimbursements are now based on that. So I want to just talk very briefly, 3 slides I believe it is, about value-based purchasing. Every year there's what's called domains, which is kind of what are the things that we're really interested in. So just for sake of simplicity, I chose 2018 domains because that's close enough to where we are now to kind of look ahead. And for the reimbursements, the methodology of value-based purchasing, 25% of that impact is going to come from safety. So here's a list of things. They are all related to patient safety indicators. If you're in the clinical field at all, and if you are seeing patients or reviewing charts, these should be very familiar terms to you. Trying to reduce the number of urinary tract infections caused by catheters, the number of infections caused by an IV in a central vein, for example. C. diff, or Clostridium difficile, is an infection that causes severe diarrhea. It's also confusing because Clostridium difficile infection is also abbreviated CDI, but anytime I've said CDI today, I'm not talking about Clostridia difficile. MRSA, or methicillin resistant, I'm going to talk about PSI 90 in a minute. Elective deliveries and surgical site infections. So 25% is based on safety. So the things that we're about to be talking about have a pretty major impact in reimbursements. The second area is clinical care, also 25%. These should look fairly familiar to you: acute MI, heart failure, and pneumonia, and the 30-day mortality rates. That's one of the measures currently being used for the clinical care. And the other 2 I'm listing here. That's the HCAP scores, which is basically the patient satisfaction, and the efficiency and cost reduction. It's hard for me to argue that CDI, documentation improvement, impacts your HCAP scores, and it's hard for me to argue that it really impacts efficiency and cost reduction, although I can make that argument. I'm not going to today because I'll be happy with 50%. The first 2 that are in bold, the safety and clinical care, that's the answer to the question, what's the role of CDI in value-based purchasing? And that's a question that I do get asked often. You notice I left the parentheses at the end of there because I had a spare one and I wasn't sure what to do with it, so I stuck it there. But when you're worried about value-based purchasing, this is the impact that documentation improvement can have. So I mentioned PSI 90, Patient Safety Indicator 90. Nobody's been able to tell me where the number 90 came from. I thought if you added up the numbers of the components of it, it would come to 90. It doesn't. And there's nothing that I can find that actually corresponds. So apparently somebody decided, well, we would probably have a total of 89 when we're all done, so we'll make number 90 the full composite. And 90 is basically a weighted average of these PSI, patient safety indicators, and that is one of the major measures that's being used for value-based purchasing. Now, I'm going to go into just one of these in a little greater depth, and then we're going to be running out of time, but I warned you that there's a lot of text on here. These are that way so that you can see them in your handout. All of these PSIs basically have inclusions and exclusions. You're going to get included in the PSI category if you have a secondary diagnosis of a pressure ulcer. In other words, you came in for something else and then a pressure ulcer developed, especially if it's a HAC, hospital-acquired condition. And you're going to be excluded. You don't have to report it if that ulcer is the primary diagnosis or if it was present on admission. So very, very important. You can see why documenting POA, present on admission, is extremely important. Patient was transferred in from another healthcare facility, and it was present on admission, so a patient came from a nursing home and has it, you don't get dinged for it. So that is exclusions. If you have somebody who has a paraplegia, for example, or anoxic brain damage, that will not, you won't be dinged for the pressure ulcer. So we did talk about in that slide with the red and blue boxes, talked about the fact that you're going to be looking for patients that are candidates to be reported, but try and find out if they have an exclusion. Now I'm just going to do one more in detail, and that's the one that I just love saying, iatrogenic pneumothorax, air in the chest cavity that was caused by something the doctor did. This is really very interesting because the exclusions are so extensive. To me, the exclusions represent the indications. These are the reasons I would be doing something that caused the iatrogenic pneumothorax. So if there is a pleural effusion, fluid in the chest cavity, I might put a needle in to try and drain that off. And if I'm not careful and I ding the lung, then I will get a pneumothorax. So to me, the pleural effusion shouldn't really be an exclusion. That was the indication. But this is interesting mainly for that reason, that this shows you what happens when you let a committee loose on coming up with things. So I am simply just going to point out that in the rest of the slide deck and in your handouts are some more of the patient safety indicators. These are very sleep-inducing. If you're having trouble sleeping at night, you can use them. As a matter of fact, last time I gave this lecture, I took a picture of the audience about halfway through the talk just to see and record their reaction. And you can see what happens when you try and read these in great detail. So again, I'm just zipping through these to simply say that they are there. They're available for you to go through. PSIs, find the inclusions, find the exclusions. So we talked about value-based purchasing, what it is and how it impacts reimbursement. And the two things that are going to impact most directly are the patient safety indicators, the safety category, and the clinical category, so the mortality rates and documenting that. So we've been over quality, impacting the O to E ratio. We've talked about metrics and trying to avoid the vanity metrics and stick to things that are key performance indicators. And we've talked about the things that are going to help with the value-based purchasing. So I just want to leave this on the screen for a little bit, and I will come back to this. This will also be in your email. This is in your handout. If you open the PDF, you should actually be able to click on this, either the text of the link or the AHIMA approved CEU icon. And from that PDF, you can be taken directly there, or as I understand it, you will also have an email coming to you tomorrow. So I'm going to see if there's any last questions. We're almost at the 3 o'clock mark. You got any more questions for me?
Yes, it's kind of a long one, so do you want to take it, or do you want to just answer it in email after the fact?
I think probably, without knowing what it is, I think probably by email in the interest of time.
Okay.
And then I'm going to kick things back to you, see if you guys have anything to close with.
No, I'll just review just a couple of instructions. So thank you, everyone, for attending. And, of course, thank you, Dr. Elion, for presenting such a great webinar.
Excuse me, can I jump back in for just 1 second? We are going to be following up with an email to everybody because if there's some things that I mentioned about our software, our reports that you found interesting, and you'd like to get a more complete demo, we didn't want to do that during the talk today, both in the interest of time and also to keep this pure just on the academic side. But we will be following up with you by email, and we're going to offer 3 time slots for demonstrations. You can see some of these things in greater detail. Thanks.
Yeah, thank you. So a couple of follow-up. You'll receive an email from me with the link to the evaluation in case you know you're not. It's difficult to click on this link from a PDF version. So we will send you an email with the link to the webinar evaluation. Once you complete that, you'll be brought to a place where you can download your CEU certificate. So that will be coming out by tomorrow morning. Look for that. We'll also have a link to the webinar recording, so you can share that, watch it again, download the handouts. If you have any problems, just reply to that email, and we'll make sure that you get your certificate. and keep a lookout for that email Dr. Elion mentioned with some invitations to public webinars if you are interested in seeing what the ChartWise solution has to offer. So thank you everybody again, and we will see you on our next webinar.